I am going to introduce the session with a talk on periprosthetic fractures, and you'll know that the rest of this session is going to be dedicated to really a discussion of the most important, or some of the most important complications of total hip arthroplasty, with the exception of infection. But we'll be talking about management of periprosthetic fractures, we'll be talking about hip dislocation and leg length discrepancy, all in this session. My talk today is aimed to give very briefly a little bit of background about periprosthetic fractures. Then I'm going to speak specifically about one technique that we've been using of attacking the so-called Vancouver type B2 and B3 fractures. Those are fractures associated with a loose implant. Rather than give a long overview of the topic, I'll invite any of you that want to hear an overview of the topic to come to the International Hip Society meeting tomorrow, where I have a longer talk on the topic. So with that background, I will talk about treatment of periprosthetic fractures with revision hip arthroplasties, and we'll talk about the results of using a specific category, not brand, of stem. I'd like to acknowledge my co-authors, Drs. Abdel and Llewellyn, who are my colleagues at the Mayo Clinic. I receive royalties on certain hip implants from DePuy, none of which are discussed in this talk, and one author, Dr. Llewellyn, receives implant royalties on certain hip implants from Zimmer, none of which are discussed in this talk. So I think we all recognize that the complexity of periprosthetic fractures often leads to suboptimal management and even poorer results of periprosthetic fractures. We recognize these are a difficult problem because the surgeon needs to do two things: fix the fracture and gain implant fixation all at the same time. By the same token, we recognize non-operative management is a relatively poor means of treatment, and we've recognized that surgery, without question, is the standard mode of treatment. What we've also recognized, and I think all of you are already familiar with, is that with an algorithmic approach to management, one can simplify the intellectual aspects of figuring out what to do with a fracture and then contemplate the technical elements of how best to solve the problem. And I think all of you recognize that in general, for so-called B1 fractures, those are in which the fracture has a well-fixed implant. The standard form of treatment in most, but not all cases, is internal fixation. I will not talk about that type of fracture today, but there are two papers in this section which will discuss that topic. For fractures that are so-called B2 fractures, that is a loose stem with a fracture, the standard form of management is to deal with both problems simultaneously. That means fixing the fracture and revising the implant all in the same setting, although I think you're going to hear another alternative approach to that from one of the other speakers later on. And finally, for so-called B3 fractures in which the stem is loose but the bone is horrible, the standard form of treatment has been revision with proximal femoral substitution, and I'll talk with you today about an alternative to that approach. So my talk will focus only on the topics of loose stems and stems which are loose with worthless bone, the so-called B2 and B3 fractures, for which standard treatment involves some form of revision. And we all recognize the main and important revision principles that are used for any type of periprosthetic fracture which is being revised. And these are the following general concepts. Use the fracture for access to remove the implant. It's already open. That's your doorway. Bypass the fracture, usually with a long stem. Use the intramedullary element of the implant to gain fixation of the fracture for the most part, and then augment that as needed. Of course, stabilize the fracture, but importantly, get stable implant fixation. It's the last category that has been the greatest problem historically with management of these fractures. Now, we all recognize that there's many ways of approaching this problem, and many of them can be successful. And I don't want to suggest that there's only one form of management that is successful. And there have been reported results with cemented implants, with a variety of different types of uncemented implants, and of course with tumor implants for certain very difficult fractures. Our philosophy at the Mayo Clinic, where I work for the last 10 years, has been to try to bypass the fracture, in most cases, with a fluted tapered modular stem, although I will also say there are other types of uncemented implants that can also do the same thing. The idea here is that you can gain both axial and rotational stability distal to the fracture site. That's the key and the important principle, because then you no longer have to rely on the damaged proximal femur for early implant support. This allows the surgeon to save the proximal fragments. It allows the surgeon to keep them vascular with minimal muscle stripping. We know that's the key to healing of the femur. In most cases of trauma, it's also true around joint implants, as I'll show you in a minute. We then bypass the fracture with, in this case, a fluted tapered stem, but there are other approaches, as I've already mentioned. But the key point here is to allow the proximal femur to reconstitute with a healing response, because you're not relying on this aspect of the proximal femur for support. You're fixed distal to that and supported distal to that. Our technique has been to access the fracture and the implant really only through fracture lines or through osteotomy lines. In other words, avoid the temptation to disassemble the whole fracture, strip it of muscle, remove all the hematoma, and damage the healing response. Access only through fracture lines or osteotomy lines. And then eventually to use the prosthesis as an internal scaffold around which you pull the bone at the end and simply allow the bone to be reassembled around that sturdy implant, which is fixed in the femur below the level of the fracture. And the reason why we think that this has been particularly helpful for us is in some ways it has simplified the Vancouver classification of fractures really to two main categories. The category where the stem's well fixed and internal fixation is the treatment, or the category where the stem is loose and this form or some similar form of reconstruction is approached. So this technique really allows the surgeon to treat virtually all fractures around a loose stem, either Vancouver B2 or B3 fractures, in a similar manner, because the concept is applicable to most fracture patterns in a relatively simplistic manner. I thought you might be interested in our results of this technique. We have treated 44 patients between 2000 and 2006, Vancouver B2 or B3 fractures, 24 women, 20 men, average age 72. All these patients followed for a minimum of 2 years or till death, and the average is 4 years. The implants were all fluted tapered modular stems. The two specific types of implants are listed. Patient follow-up. 3 were lost because of inadequate radiographs. We're still tracking them down. And 2 patients had the implants removed early due to infection. Therefore, I'll report to you on the results in 39 patients. Of those 39 periprosthetic fractures, our fracture healing rate was 97%, so 38 of the 39 fractures healed. And we had a stable implant in 38 of the 39 hips, also for a 97% rate of implant stability. And compared to our other sister series from our own institution with cemented implants, with extensively coated implants, and with proximally coated uncemented implants, these results are notably superior, although, of course, it's not a prospective randomized series. I'll just show you some examples of the technique. This is the simplest situation, a short stem with a relatively easy fracture, treated with a short fluted tapered modular stem. You can see early healing and a stable implant even after only 3 months. A more typical type of fracture with a standard B2 fracture, the stem is loose. You can see it's debonded from the cement. There's osteolysis near the tip and a fracture. You can see the standard form of treatment, which is fixing the fracture up here with just a few cables, keeping this all vascular, implant stable distally, robust healing response. In this example, which I think says it the best, this is a Vancouver B3 fracture. You can see the patient has a relatively fragmented femur. You can see good remaining bone here. We've placed an implant which is stabilized here on the femur, rotationally and axially. The proximal bone has really been mostly left alone. We've opened the femur and then closed it. We've left the hematoma in place. And you can see after 2 years the very robust healing response which has occurred simply by leaving that bone alone and allowing it to heal the way the femur likes to do. Complications. I already mentioned to you the 2 hips that became infected. There were 5 hips in this series that had dislocation problems. And by the time of the last follow-up, 9 patients had died for reasons unrelated to their fracture or surgery, which I do think points out an important element of this, that many of these patients that have these fractures are old, feeble, and sick, and don't have a long longevity, although some of them, of course, do. So I'll conclude by saying that this, we think, is an evolving technique which places emphasis on simultaneously creating a strong and durable mechanical construct and at the same time optimizing the biologic environment for fracture healing. I don't mean to suggest this is the only category of implant that allows you to do that, and there are certain other categories of implants that many of you may use that would also provide similar effectiveness in this type of treatment. So I'll conclude by saying that fluted tapered stems for periprosthetic fractures require revisions, a simple, straightforward, reproducible technique with a very high rate of implant stability and fracture healing in our hands, and it allows the surgeon to intellectually treat Vancouver type B2 and B3 fractures with a similar approach to the problem. Thank you very much for your attention.
Thank you very much, Dan, for your excellent paper. Is there some question in the audience about this very difficult problem?